Hi, everyone. This is Dr. Saul, and in this recording, we're going to talk about testing and measurement issues. So looking at measurement, this is the basic core of all research. So with measurement, this is what we are going to be looking at as far as really understanding what it is that we're measuring. So for certain concepts, this could be things like depression, anxiety. For others, it could be weight. It could be your balance skills. It really depends on what it is you're looking at as to what that measurement is, but it is that basic core of all research. The assignment of numbers or perceptions or behaviors to occurrences. So like I said, numbers being like your weight, perceptions being your perception of your anxiety, depression, mood, behaviors that you're exhibiting, and those could be measured through observations, all different things that you can use measurement for. Exactness and precision in measurement are vital to the trustworthiness of your data. And there's basically two basic processes: conceptualization and operationalization. So conceptualization is providing or assigning a conceptual or theoretical definition to a construct or concept. It includes conceptualization of things like love or understanding like different concepts. It's consistencies in literature, new conceptualizations that challenge the norm, so things that you may not have considered before, and guided by researchers. So there's usually some type of theoretical framework of science that helps with this conceptualization. So something that we talk about in recreational therapy is something known as like flow, for example. And so flow is, when you get into that state of hyper focus and are able to be really productive and completely into whatever it is that you're working on. And so that was a concept that needed to be conceptualized, and then a theoretical framework was developed by Csikszentmihalyi to be able to fully explain what this process looks like and what is happening during this process. And so that's that conceptualization. With conceptualization, it's important that it's consistent, because you want to make sure that what you're measuring is what you're conceptualizing. And you want to make sure that you're measuring it the same way every single time. Operationalization is another part. And so this is the process of taking the conceptual definition and making it more precise. So this is where you would be linking that conceptual definition to a more concrete indicators or operational definitions. And it provides a more precise way of measuring. So here are some examples to be able to really see what I'm talking about with that operationalization. So an example would be overconfidence. So this would be the difference between how well people think they did on a test and how well they actually did. Or this could be the difference between where people rank themselves compared to others and where they actually rank. Another concept would be creativity. So this is the number of uses for an object, for example, a paper clip, that participants can come up with in 3 minutes. Another example with operationalization of creativity would be the average rating of the originality of uses of an object that participants come up with in 3 minutes. Next is perception of threats. So this could be physiological response of higher sweat gland activity and increased heart rate when presented with threatening images, or it could be participants' reaction times after being presented with threatening images. And lastly is customer loyalty. So customer ratings on a questionnaire assessing satisfaction and intention to purchase again, or records of products purchased by repeat customers in a 3-month period. And so these are all concepts that are operationalized to be able to specifically measure them, as you can see in these examples. So with levels of measurement, there's different ones. So there's nominal, ordinal, interval, and ratio. So looking at nominal, so this would be categorical in nature. And so things like, what is your gender, or what is your sex, male, female, or it could be distinct categories. So this could be things like your race, your hair color, those sort of things. It's usually discrete in nature in that it has like a yes or no, or a male or female, certain discrete options. So with this, it also can be continuous or unlimited values. And usually it is mutually exclusive. So for example, gender, or it could be your religious preference. Those are different examples of that nominal in nature. And so here are some examples of questions that you may see. So one being, what is your gender, male or female? What is your hair color, brown, black, blonde, gray, or other? Where do you live? North of the equator, south of the equator, neither, in an international space station. So just different options of ways that you can ask these questions, but they are nominal in nature. So it's just a name. There's no order or levels involved. It is just categories: male, female, black, brown, blonde, hair, all of those different things. The next is ordinal, or order. And so this is variables that are ordered or ranked. So for example, this could be your judgment. So on a scale of, where it has different options from like strongly agree to strongly disagree, where do you rank these different things? Or it could be from very important to not important. Excuse me. With this, you are not aware of the distance between ranks. So it's not like on a scale of 1 to 7, where would you rank yourself? It's just different categories of rank. With this one, there's no common unit. And so it's just things like strongly agree, agree, strongly disagree. And so here's an example. So please indicate how much you agree or disagree with the following aspects of user's experience are important to consider. So strongly agree, somewhat agree, neither agree or disagree, somewhat disagree, or strongly disagree. And then they would pick. And so there's no specific numbers that are associated with this. It's just pick one of these options. The next one is interval, where you have equal intervals. So you would have equal distance between different things. This is helpful for meaningful distances between ranks, different rates of different things that may happen, all of that. So interval could be measurement. So for example, 3 feet. It could be ordered. So it could be something where you are, have a ranking system, or it could be something that's equal distant. And so that would be like the difference between, let's see, for example, it would be something like 1 foot, 2 foot, 3 foot. It would not be like 1.5 feet, 1.5 or 1.75, like 1.25. It would be, everything is a specific standard distance between each thing. And there's no meaningful zero. So things like where you could have a zero, like that could potentially be on a scale of 0 to 10, what would you rank yourself? So a 0 would not work for interval data. Ratio, on the other hand, has that interval aspect, but also has an absolute or true 0. So for example, temperature would be something that can be 0. Length or weight could also be 0. It's a common unit of measurement usually. So just this kind of goes into more detail about that. So has an absolute zero characteristic. It has orders and equally distant values between units. So for example, temperature. Ratio scale data does not have any negative numerical value. For example, weight cannot be negative 20 kilograms. That does not exist. The data values of a ratio scale can be added, subtracted, multiplied, or divided. All statistical analysis can be calculated using ratio data. It has ratio scale units, which have several unique and useful properties. One of them is they allow unit conversion. So from like grams to calories, kilograms to calories, just different conversions that can be done because these are specific scales. So this kind of summarizes the differences between the different types. So starting with nominal at the bottom. So this is categories, no ordering or direction. Next one would be ordinal data. So this is ordering categories. So ranking, order, or scaling. And both ordinal and nominal would be what we call qualitative data. The next one is interval data, which is the difference between measurement but no true zero. And ratio data, which is the differences between measurements, true zero exists. And both of these, interval and ratio, would be considered quantitative data. So with looking at precision of measurement, so the precision increases as you go from nominal up to ratio. So there's more precision with ratio measurement. The higher the type, the more precision. Every level up includes properties of the previous level. So you could see that again here as well, of going from just a category up to a true measurement. And so again, just another summary. So with looking at this, you can see how nominal only has categorized and labeled variables all the way up to ratio, which has that true meaningful zero. And so this includes all of those different aspects. And so to continue, I just wanted to give you guys some different examples of options of these could be nominal, ordinal, interval, or ratio. So I want you to kind of determine which one you think is each of these options. So first one being a year in school, IQ scores, fatigue, GPA, hair color, type of neighborhood, and climate. And so determine based off of what we've talked about where you think that these all would fall. And then looking at reliability and validity, we've talked about this before, but with reliability, again, that is how trustworthy the data is. Is it repeatable? Is it consistent? And validity being, does the instrument measure what is intended to be measured? For example, pain versus anxiety. It needs to be specific that you are measuring pain, but not both pain and anxiety. And so being able to really pinpoint that. Some different threats that can be found to measurements specifically related to reliability and validity. And so there's multiple different ones that can occur. So the first being ambiguity. So when correlation is taken for causation. So if you've ever heard that saying of correlation does not mean causation. So for example, there are higher risks or higher drownings after children eat ice cream, for example. Although there may be higher drownings, they may not be correlated with ice cream, but you eat ice cream usually in the warmer months when you are swimming more. And so the swimming can potentially lead to drownings, which could potentially lead to deaths, but it's not the ice cream's fault for those people drowning and dying. And so it's that correlation does not mean causation. So they're correlated, but they're not caused by one another. The next one would be apprehension. And so this is fear that somebody may have about completing your assessment, and therefore may not complete it. And so that's a potential threat to being able to actually administer and receive appropriate data from that individual, or that they may think that you are, trying to lie to them, or what their score is may dictate what happens to them next. And so then they're more apprehensive about completing that assessment. Compensation, so financial influence, can also be a threat to reliability and validity. So if you were to have people pay or get paid to be able to be part of your research study, for example, that could potentially lead to invaluable data. Another one is demoralization or boredom. So that would be like, for example, when I talked about Christmas treeing. So they may Christmas tree their results on a self-assessment. If you've ever done that, you've ever had to complete a survey, for example, and you get tired of answering the questions or just want to get on to whatever's next. And so you just kind of put down 10s for everything, or you just randomly pick answers throughout. Diffusion is mimicking responses. And so this could be that you've already taken this assessment, and so you're just going to do the same thing you did the last time. Or if somebody asked you, like, on a scale of 1 to 10, what do you rank your anxiety? And then you do it again at the end, and you could just mimic your response without actually really trying to appropriately answer based off of whatever's happened. And then the next one is history. So events that may occur between pre and post. So say you do an initial assessment with somebody and you give them a score on an assessment, then something happens to their health and they decline, and then you give them that assessment again. That health decline may influence their post-assessment. And so it may not be related to the interventions you provided, but related to their health. Or it could even be like an event that happened, like, for example, if you're looking at some type of mood or like anxiety, depression, and you did it with individuals before COVID-19 and during COVID-19, that would also have an influence. Or the example here of winning the lottery, all of those different things could potentially be an influence on an individual's results from their initial assessment to their next assessment. Additional measurement threats to reliability and validity are inadequate operationalization. So this is where there are unclear definitions. And so the individual who's taking the assessment or the one who developed the assessment is not clearly understanding what needs to be measured and not measuring it appropriately. Instrumentation is changing the instrument and assuming that you're going to still have the same results. It could even be as simple as like a different scale for weighing somebody that could have an influence on their results. Interaction, so this is confounding treatment. So when two things work together to see results, for example, somebody who is on a weight loss drug while also exercising, those two combined could interact and help them to lose more weight than just that exercise program. It could also work the opposite way. Somebody who is exercising daily and also eating really bad food for them may not lose the weight, and it wouldn't be because of the exercise program, but it could be because of the food habits that they have. And then maturation is natural changes in the sample. This usually happens more in longer term studies or long assessments. So for example, if you were assessing somebody at 18 years old and then again at 28 years old, their sample is going to change just due to them getting older during that time frame. Another one is mortality. So this could be somebody who potentially passes away or who quits during your research study. The next one is regression towards the mean or the tendency toward middle scores. So this would be, kind of when we talk about if you've heard of in like classes or with other peers, people talking about a curve, and that there being like a natural curve to a course. So basically there's this natural curve that can be really anywhere, but there's this tendency towards the middle and wherever that middle is. So for example, it could be a tendency towards a C average in the class, for example. And so there's going to be a majority of the people in that range, and then a few Bs, a few As, a few Ds, a few Fs. And so there's this natural curve that you would see. There we go. And so with that regression towards the mean, so you would have some type of curve kind of like, let's see, kind of like this, sorry, a little harder to draw on here. And so the mean would be here. And so you'd have most people kind of in this area. And so everybody kind of gravitates towards that center, whatever it is. So maybe in this case, for this class, it's like a B. So everybody kind of, the majority of the class would be in that B range, with a few people over here in the C range, and then a few people over here in the A range. And so the majority of people in the class would be in that average range of a B. And so that's the curve that you would see. Okay. So moving forward, so the next one would be, what just happened? Rivalry. So this would be scores influence due to competition. And so this is another thing you want to probably avoid within the setting that you are working in, because you don't want people to be competing against each other, which could potentially cause them to hurt themselves or for something to happen. You want everybody to be able to be as successful as possible. Selection, so volunteers who self-select themselves to be in your study, they're more likely to be kind of influenced by what's going on and to want to be successful. Setting, so the setting or context may also influence how they do. So if you've ever taken like an exam in a really noisy setting versus taking it in a very quiet, comfortable setting, how your score may change based off of that setting where you're taking that exam. And so making sure that the setting is appropriate for the clients to complete that assessment. And lastly is treatment. So the Hawthorne effect of people trying to gain attention or wanting to be successful, and how that may play a role as well. All right, so next up is clinical reasoning. So this is the cognitive process that involves professional thinking logically and coherently about the possible reasons and meanings related to a situation. So clinical reasoning is your expert judgment on the part of the therapist to make appropriate decisions for what treatment based off of the assessment would be appropriate for that client, focused on producing the best actions in a particular situation. And so based off of your experience, you should reach a level of high clinical reasoning. Assessment and codependency issues. So healthcare relationships provide certain dependency issues. Specifically, this could be, where the client is constantly getting what they need out of the facility. And so they have this kind of learned helplessness. And so they're highly dependent on that facility, and then they end up being discharged and have to figure it out on their own. And so kind of teaching them how to do those things. So this could be how much the therapist cares about the client can cause the therapist to rate the client higher. Patient codependent on understanding that if they get better, they will no longer have the therapist, so they will stay unhealthy so they can stay with the therapist longer. All of these different kind of codependency issues that may occur. And so the patient may kind of skew their results based off of that, or you may have a bias towards certain patients and that may skew their results as well. So making sure that you avoid doing that. Computers in assessment, so making sure that your computer or the systems you're using aid in the statistical analysis of results, making sure that they are not negatively impacting your assessments. And that you are also making sure you are interpreting the results and making sure that it matches what the computer says it should be measuring. Adapting tests, so there may be somebody with like an visual impairment, for example, so you may need to increase the font size or maybe have different contrasting colors. So like black with white is really helpful for people with a visual impairment because they can see that clearly. Central placement of different items, those sort of things can be really helpful. Those with limited communication, maybe having an electronic device or pointing boards can be helpful to make sure that they are able to actively communicate with you. Looking at gross motor, so changing positions or size of objects to manipulate the assessment so that they can be properly assessed. Or also language, so interpretation of questions, making sure that if there is a version for their specific language, that you're choosing that version over choosing one that, like for example, if they their first language is Spanish, and you have the English version of the assessment, can you find the translated Spanish version? And if so, use that version instead. This is something that they've actually done with the CTRS exam that you all will take in order to become recreational therapists, where they have multiple different translations now that they've proven to be accurate, reliable, valid in measuring what they're supposed to be measuring and asking the same questions as the English version. Also with language, visual symbols rather than a narrative. Specifically, this could be important for children that can't read or those with some type of developmental disability. They would need some type of visual symbols instead. Next is honesty and deception. So making sure that you are interpreting the assessment and that you are making sure that the client is not manipulating you or doing anything to be deceitful. So malingering, so conscious fabrication or exaggeration of symptoms. Again, this could be for somebody who does not want to leave the facility or has fear of something happening if they leave. Defensiveness is denial or minimization of symptoms in order to seem that they are healthier than they are or that they are not in need of treatment, those sort of things. Irrelevant responding is response style reflects limited engagement in the process. Honesty and deception continued. Random responding, so random patterns of response, not really staying with a clear road of answering all the questions appropriately, but maybe kind of all over the place. Honest responding would be patient, sincere attempt to be accurate. And hybrid responding would be a combination of different response rates. So they may be random at points and honest at other points. Again, it could depend on the assessment. It could depend on a lot of different things. Like, do they want to show that they're doing well? Are they bored and just tired of doing the assessments at this point? And so they just start Christmas treeing? What is happening? Social desirability is when clients respond in a manner that makes them look good in the eyes of others. And this is something that happens specifically with different assessments because the client doesn't want you to think of them any differently than they are. And so they may score themselves higher to help you to see that they're doing well, even if they may not be. This can be used for denial or defensiveness. There's the Crown-Marlowe test, which has repeating answers in different manners to test honest responses. So different things like that can be used to ensure that the answers are appropriate. Self-disclosure is another one. So an ability to disclose to a therapist. So this may be related to trust issues, not having rapport with the therapist and therefore not wanting to share, or the inability to share in certain populations, there is, that negative connotation towards mental health, for example. And so they may not want to let you know of certain things that have happened to them because of fear of the repercussions that may ensue. Cultural barriers is another one. So beliefs within a culture that inhibit accurate assessment. And this also relates to, what we've talked about before of different cultures may impact their interpretation of the results or their ability to think that something may be healthy, unhealthy. An example that's coming to mind would be like the amount of alcohol that someone drinks per day. For certain cultures, they should not drink alcohol at all. And for other cultures, drinking a glass of wine with dinner every night is seen as normal and not seen as being an alcoholic, for example. And so that cultural barriers, they play a role as well. And cultural bias of your culture and what you know as being quote unquote normal may be different than somebody else's culture. And so you may have that bias or that negative lens that you may be looking through when assessing and interpreting assessments. And so keeping all of that in mind. And lastly, trait versus state. This you'll see with different assessments, the most specific one being the state trait anxiety inventory. And so with this, traits are long-lasting and enduring characteristics, fairly consistent throughout the lifetime, learned patterns of thoughts, things that you're born with. So for example, like a type A personality would be a trait. State, on the other hand, is short-lived, usually a direct result of a situation or environmental impact. So this would be, for example, your stress level after being cut off in traffic. How is that going to look versus you after a relaxing spa day? What is your stress level going to look like on that day? And so the state can be very variable in that it's always all over the place depending on the circumstances and the things that are happening. However, your traits usually do not change very much over time. And they're definitely not changing with different things that happen. Usually people with, for example, the type A personality are going to be more anxious, more high strung, more focused and time conscious and those sort of things compared to somebody else who may be more relaxed, not really get bothered by different stressors that occur. And so therefore they may have a lower trait anxiety. All right, that is all that I have for you all for today. If you have any questions, please let me know. Thank you.